Keloid disease is a chronic skin disorder characterized by the excessive formation of scar tissue at the site of a healed skin injury. Unlike normal scars, which are typically flat and confined to the original wound boundary, keloids grow beyond the initial injury, forming thick, raised, and often irregular lesions. These lesions can develop after various types of skin trauma, including cuts, surgical incisions, burns, piercings, acne, vaccinations, or even minor abrasions. Keloid formation is a result of an abnormal wound healing response, in which the body produces excess collagen and extracellular matrix components. Etiology and risk factors. The exact cause of keloid formation remains unclear, but a combination of genetic, environmental, and immunological factors contributes to its development. Individuals with darker skin tones, particularly of African, Hispanic, or Asian descent, are more prone to keloid formation. Genetic predisposition plays a significant role. A family history of keloids increases the risk of developing the condition. Certain regions of the body, such as the chest, shoulders, upper back, and earlobes, are more susceptible due to higher skin tension and mechanical stress, which may trigger excessive collagen deposition. Hormonal factors may also influence keloid development. It has been observed that keloids are more common during puberty and pregnancy, suggesting that sex hormones can modulate fibroblast activity and scar tissue formation. Furthermore, repeated trauma, infections, or prolonged inflammation at the wound site can exacerbate keloid growth. Pathophysiology. Keloids result from dysregulated wound healing. Normally, wound healing occurs in 3 overlapping phases: inflammation, proliferation, and remodeling. In keloid disease, this process is disrupted during the proliferation and remodeling phases. Fibroblasts, the primary cells responsible for collagen production, become hyperactive and continue synthesizing type 3 and type I collagen long after the wound has closed. Growth factors such as transforming growth factor beta, TGF-beta, and platelet-derived growth factor, PDGF, are overexpressed, stimulating fibroblast proliferation and extracellular matrix deposition. Unlike hypertrophic scars, which also involve raised scar tissue but remain within the original wound boundaries, keloids extend beyond the site of injury and rarely regress spontaneously. The lesions often contain an excess of blood vessels, inflammatory cells, and proteoglycans, contributing to their firm texture and reddish or purplish color. Clinical features. Keloids present as firm, raised, rubbery nodules or plaques that can vary in size from a few millimeters to several centimeters. They are usually painless, but some patients experience itching, tenderness, or a burning sensation. The color of keloids may change over time, starting as red or purple and eventually becoming dark brown or pale. Keloids may cause functional problems if located near joints, restricting movement, or in cosmetically sensitive areas such as the face or ears, leading to significant psychological distress. Diagnosis. Diagnosis of keloid disease is primarily clinical, based on patient history and physical examination. Keloids are distinguished from hypertrophic scars by their growth beyond the original wound boundary and persistence over time. Dermoscopy and imaging techniques such as ultrasound may help assess lesion thickness and vascularity. In rare cases, a biopsy may be performed to rule out other skin tumors or fibrous growths. Treatment and management. Management of keloid disease is challenging due to the high recurrence rate after treatment. Approaches include both non-invasive and invasive strategies. Non-surgical therapies. Intralesional corticosteroid injections reduce inflammation, fibroblast proliferation, and collagen synthesis. Silicone gel sheets or topical gels flatten and soften the keloid by hydrating the scar and regulating collagen deposition. Cryotherapy, freezing the keloid, can reduce size and symptoms. Laser therapy, pulsed dye lasers improve appearance and vascularity. Surgical options. Surgical excision of keloids is often combined with adjuvant therapies, such as corticosteroids or radiation therapy, to prevent recurrence. Surgery alone has a high risk of the keloid regrowing, often larger than the original lesion. Radiotherapy. Low-dose radiation after surgical removal can significantly reduce recurrence rates, although careful consideration is needed due to potential long-term risks. Emerging treatments. Research is ongoing into treatments targeting molecular pathways involved in keloid formation, including TGF-beta inhibitors, 5-fluorouracil, interferon therapy, and other antifibrotic agents. Prognosis. Keloid disease is benign but often persistent and recurrent, making complete eradication difficult. While keloids do not pose life-threatening risks, they can significantly impact quality of life due to pain, itching, restricted movement, or cosmetic concerns. Early intervention, individualized treatment plans, and preventive measures following skin injury can help manage symptoms and reduce recurrence. Conclusion. Keloid disease represents an abnormal fibroproliferative response to skin injury, with excessive collagen deposition leading to raised, firm scars that extend beyond the original wound. Genetic predisposition, skin type, hormonal factors, and wound tension play key roles in its development. Although various treatment modalities exist, managing keloids remains complex, often requiring a combination of therapies to achieve optimal outcomes. Patient education, early treatment, and preventive strategies remain essential to minimizing the physical and psychological impact of this condition.